You can start now. Go live.
Okay. Good afternoon, everyone. Welcome to our very special live program on Cancer Reach. Cancer Reach is initiated by Dr. Krishnamani to spread awareness about the cancer and help the caregivers and patient to access the right treatment on right time. We have all learned a lot about what is breast cancer and basics on breast cancer from Dr. Krishnamani in our many previous sessions. But yes, what is new in breast cancer is always an exciting topic for everybody and always an curiosity to know new and to learn new. So today, our esteemed guest, Mr. Dr. Krishnamani, will share and many interesting, latest and exciting information on what's new on breast cancer. So please join me on welcoming Dr. Krishnamani from American Oncology Institute of Hyderabad. Thank you, Doctor. Thank you for joining us today, Doctor.
Hello, welcome to Cancer Reach. Cancer Reach, as you all know, is an initiative to spread awareness about cancer. And October is a breast cancer awareness month. So we wanted to start this awareness month with the discussion on what are the newer options in breast cancer or newer treatments in breast cancer.
So, Doctor, when you were saying about newer in breast cancer, what is new actually right now in breast cancer we can see?
See, as you said, we've all discussed about the basics of breast cancer, right? Our aim is all about awareness. So we spoke about how one presents, what are the symptoms, what do you do to do a diagnosis like a biopsy, scans, how do you treat, what are the types of breast cancer. But science is a field which keeps changing every day. And even in breast cancer, that there has been so much progress. From a patient point of view, it's highly curable if it is detected early. The cure rates of stage 1 and stage 2 breast cancers are more than 90%. Stage 3 is more than 70-80%. So despite such high cure rates, there is some space for improvement. How can we make the cure rates even higher? How can we reduce the side effects for patients? How can we improve their quality of life? So in all these areas, there has been a lot of development, and every year there is some development. So that is the new thing in breast cancer. That could be in hormonal therapy, that could be in HER2-based therapy, that could be in surgery, that could be in immunotherapy. So we want to discuss some salient features in the first 9 months of this year, what has happened from Jan 24 to September, October 24. What are the new studies or what is the new things which has had an impact on breast cancer, which will have an impact on patients' treatment. So patients tomorrow can think about these options or discuss with their doctor that there are some changes in the treatment itself. So am I a right candidate for that? So that is what we want to discuss so that they can have a discussion with their oncologist.
Wow, Doctor, looking into this, some latest new technology, I guess the improvement in science is very high. So, Doctor, you were referring something like on immunotherapy. So, Doctor, what is exactly an immunotherapy and in role in TNBC, Doctor?
So let us discuss immunotherapy first and then TNBC.
Okay,
Immunotherapy means, we have discussed earlier also, treatment which boosts your immunity to kill cancer or control cancer, number one. TNBC is triple negative breast cancer. That is ER negative, HER2 negative. We have discussed earlier in our earlier sessions, TNBC is a bad disease. It is aggressive disease. It has high chance of coming back or high chance of recurrence and high chance of spread. Chemotherapy is the only option because it is hormone negative. Hormone treatment or endocrine treatment is not given. Because it is HER2 negative, HER2 treatment is not given. So we have a bad disease and chemo is the only option. So what to do? That is where immunotherapy has come. So we have looked, people have tried to look at an alternate option like immunotherapy in a bad disease like TNBC. It has been used in the stage 4 setting or metastatic setting where there has been an advantage. Today, certain stage 4 triple negative breast cancers are given immunotherapy to prolong their life and survival. So that is why, that is one part of the story. So today that is standard. If you have advanced breast cancer, triple negative, and on the tumor we do a PD-L1 score. If that score is more than 10, you are given immunotherapy.
Okay.
Now, because it's a bad disease, even in earlier stages, people have started using immunotherapy so that the patient doesn't go into stage 4.
Oh,
So we are
okay.
saying triple negative is bad, high chance of recurrence. Why recur? What can you do to reduce recurrence or prevent it? Can you give immunotherapy before itself? Why wait till stage 4? So today, from stage 2 or stage 3, immunotherapy is given with chemotherapy in triple negative.
Oh,
This has shown an increase in the pathological response, we say. That is, after your whole treatment is over, when the tumor is removed, when the lump is removed rather, if no tumor is seen, it is called PCR, pathologic complete response. That is, on pathology, there is no tumor. There is just a lump which is a dead lump.
oh, okay.
So, adding immunotherapy to chemotherapy in early triple negative breast cancers increases the pathological complete response. So, those who took and those who did not take, these people had higher PCR. If you have higher PCR, there is a chance of higher survival. They live longer.
Yes.
So that is why what is new in triple negative and immunotherapy is use in stage 4 setting and also use earlier. In stage 4, you need PD-L1. To use it upfront, you don't need PD-L1. You just need it is triple negative. You add it with chemo. It is not without chemo. Chemo plus immuno. This is given for a total of approximately 6 months. Then you do surgery. Then again, immunotherapy alone is given for another 9 cycles or 27 weeks or approximately 7 months. Almost 1 year of immunotherapy, 6 before surgery, 6 months after surgery. And your aim is if you get a pathological complete response, this patient has a higher chance of longer survival. So today, the drug called pembrolizumab, which is an immunotherapy, is a standard drug. Right now, pembrolizumab is expensive. We always talk about the finances because our patient should not be burdened. It is an expensive drug. Under the patient access program, 1 month's pembrolizumab costs approximately 2.2 lakhs. One cycle. But under the new program called Kiran program,
Okay.
if the patient buys 5 cycles, the remaining 12 cycles are free. So, in a year, earlier a patient used to pay 2 lakhs into 17 cycles, 34 lakhs. Today, you pay 2 lakhs into 5 times, only 10 lakhs for the whole year. So rather than 34 lakhs, you spend only 10 lakhs for immunotherapy.
Oh,
But again, it's expensive treatment. We should understand that.
but doctor, like if the 10 cycles are taken care, only 5 cycles to be paid, at least the chances of survival, or as you
No,
told,
5 cycles are paid,
paid.
12 are free, remaining 12.
But the success rate is very good. So I know the treatment is expensive, but the technology has really helped the patient a lot then in this condition.
True, but again, in our country where majority people are still poor or lower middle income class, they cannot afford immunotherapy. But we should have this discussion with our patients saying that there is a medicine which when added gives you benefit. But we should also have a clear financial discussion with them.
Yes, very true, doctor. So, doctor, like, then I heard somewhere, like, what is the ribociclib role in early breast cancer?
Are you able to hear me?
Yes, doctor. What is the role of ribociclib in early breast cancer, doctor, then?
So now what is ribociclib? What is palbociclib? What is abemaciclib? So these are all drugs called CDK4 inhibitors.
Okay.
Cyclin dependent kinase inhibitors. Okay, these are basically tablets. They are given in hormone positive HER2 disease.
Okay.
They are given in stage 4 disease. Okay, so metastatic hormone positive HER2 negative cancers
Hmm.
receive either Abima or Ribo or Palbociclib with hormonal therapy, which is either anastrozole or fulvestrant. So basically, you are targeting the hormone receptor. Hormone receptor, estrogen and progesterone receptor are positive. HER2 is negative. You are
Yes.
targeting the estrogen receptor in stage 4 cancer patients with hormone therapy and CDK4.
Okay.
Okay. Now, this CDK4 in stage 4 has really benefited patients. Today,
Okay.
hormone positive, HER2 negative stage 4 patients live beyond 5 years.
Wow.
And these are tablets you take at home, you don't come to hospital for IV, etc. Your quality of life is excellent.
Wow. Okay.
Side effects are also minimal, definitely much, much better than chemotherapy. So now, the same way as we discussed earlier, people have tried to see early stage of breast cancer, hormone positive, HER2 negative only. Some of them are becoming stage 4 later after a few years.
Okay.
Why? Then they found out these patients are high risk patients. What do you mean high risk? They have large amount of axillary lymph nodes. That is when their surgery happens. They have more than 4 lymph nodes, 8 lymph nodes, 10 lymph nodes when the tumor is removed.
Okay.
They are hormone positive. Earlier, what you used to do, hormone positive, HER2 negative disease, after surgery, put them on hormone therapy, letrozole or
Yes.
anastrozole or tamoxifen. Then what we realized is some patients are getting into stage 4. So these are the high risk patients. So you're identifying in a class, for example, the student who's not studying well and you're giving him extra coaching. Same way, you're
Overwork.
finding out hormone positive, HER2 negative is a good disease, but some patients are relapsing. Why? Because they have high nodal disease. On
Okay.
removal of tumor, more than 4 or 5 lymph nodes. So people have started realizing, can we add this abemaciclib and ribociclib before itself? So that is your ribociclib. The whole story is like how it came. It is used in stage 4. It has given excellent result. People are seeing added to the high risk guys who have more than 4 lymph nodes, more than 5 centimeter tumor. Add this to, you anyway give letrozole. Add this also. Is there benefit? So right now they say give it for 2 years after surgery. In our language, they call it a DFS benefit, IDFS benefit. It's a technical term, but the data is not, we don't have that much mature data. We are just 2 years. It's a baby. This molecule is a baby right now in this. So you cannot say tomorrow it will become a winner. It will become an IAS guy or a doctor. You cannot yet say. So you have to say these are early baby steps.
Okay.
This medicine is approved in the US. So if you are hormone positive, HER2 negative, early breast cancer, and you have high risk features like more than 4 lymph nodes, then you are given the option of either Abima or ribociclib. But the patients should be said that, see, these medicines have side effects like diarrhea, liver function abnormalities. You have to take it for a longer period of time, 2 years. And the data is not very strong to support you.
Okay.
In cancer, no, the data is when you have an overall survival benefit. If some drug increases somebody's survival, that drug is beneficial. That OS benefit yet is not seen because this is a new thing.
Okay.
But again, doctors and patients should have a discussion. If I have 5 risk features, am I a candidate for this drug? Would you want me to take this drug? And does it really benefit? So this session is actually only igniting the minds so that people are aware that something new has happened and is there any role?
Very true, doctor. Through this session, no, actually many of the patients will have an options to ask to doctor for a better cure rate, doctor, like that.
More than that, I'm pretty sure their doctors will definitely talk about it.
Nice.
But let the patients also be aware that there are options available. These are newer options. They are expensive. They have side effects. The data is not very strong, but have a discussion.
So, doctor, like through this, is it like chemo can be avoided in HER2 early breast cancer? Can that be possible?
See, generally, Chemo is avoided in hormone positive, HER2 negative breast cancer in a very early stage. They usually are low risk. So this drug doesn't come at all there.
Yes, yes.
If you are high risk means you have more than 5 centimeters, you have large lymph nodes means you will receive chemo at some point.
Okay.
That is why the question also that in high risk, if at all the patient gets chemo, how much will this benefit? So that only time will tell.
Yes.
And in low risk, because the risk itself is low, why take this medicine and have side effects? What's the use when my disease anyway is good?
Yes, cure
So
rate is
these
good.
are the questions we have to answer in future.
Oh. So in short, chemo will be an option as well.
Chemo is, as we have discussed, is usually given in tumors more than 2 or 3 centimeters, in node positive disease, in triple negative, in HER2 positive. Triple negative, you need chemo. HER2 positive, you need chemo. In hormone positive, HER2 negative, if you have a large tumor or if you have lymph nodes, generally you are given chemo.
Okay.
But there are certain caveats. If you're extremely old and hormone positive, HER2 negative, you may avoid and just be put on hormonal tablets because chemo has a lot of side effects in elderly people. If you're extremely weak and frail, you are not fit for chemo.
Yes.
Those kind of things.
So, doctor, like, what is the role of ancillary USG in early breast cancer?
Now, this is something which is very interesting. See, you have a
Okay.
breast lump, you always should remove the armpit lymph node.
Yes.
This armpit. So earlier
Okay.
surgeons during surgery used to do axillary dissection. That is, they used to remove the lymph nodes in the armpit
Okay.
blindly many years back. When you remove all the lymph nodes in the armpit, your arm gets swollen. It is
Okay.
called lymph edema. Lymph is a milky fluid, and if the lymph nodes are removed, the lymph accumulates in that limb and the hand becomes big. Then people realized you don't need to remove all the lymph nodes. There is one lymph node called sentinel lymph node.
Okay.
Sentinel lymph node is like the first security guard in your house. If he is there, means the house is safe. If that fellow is beaten and fallen, that means you have to go inside. So now what they do is they do a sentinel lymph node. They give a dye.
Okay.
If the sentinel lymph node doesn't pick up the dye, there is no cancer in it. So you don't need to remove the other lymph nodes.
Oh,
So
okay.
you are avoiding axillary dissection. Okay. So now in the last year or so, there was a paper where they have seen you do axillary lymph node ultrasound. If the ultrasound doesn't pick up anything, can you avoid sentinel lymph node also?
Oh,
So what they have seen is those people who had no lymph node on ultrasound, if you did not remove their sentinel lymph node, okay, they had similar result compared to those who had the sentinel lymph node removed.
Oh, okay.
But I would say don't read too much into it. It is too early. What from Cancer Reach, what I would want our patients to understand is sentinel lymph node biopsy is standard now. A dye is given. If your node is not picking up anything, your doctor will not do your axillary dissection. It reduces obviously the time for surgery, complications, and the chances of having lymphedema, which is a very bothersome complication. See a breast cancer patient, she will tell you, my one hand is always swollen, she will tell you.
Swollen. Yes.
And this is permanent.
Oh my God.
So that's why sentinel lymph node is a blessing for patients.
Wow. Yeah, agreed, doctor. Even the edema lymph is always very like it looks very fatty, and also it is not easy to do any work with that lymph.
Correct. Prone to infections, ulcers,
Yes.
pain.
And even the movement in that hand is restricted.
Correct.
So, doctor, like this was something on axillary. What is the role of TDM1 in early breast cancer?
So again, in all cancers, molecules come first in the stage 4 and then we push it before. Let us understand.
Okay.
So in HER2 positive breast cancer, after using trastuzumab and pertuzumab, there came a medicine called TDM1
Okay.
that was used. Then people realized, can you push it earlier? Because HER2 means high risk, disease can come back. Why wait till stage 4? Can you give TDM1 before itself? So today, for HER2 positive breast cancer, early breast cancer, what do? We give chemotherapy plus HER2 therapy, that is trastuzumab, targeted therapy. So chemo plus trastuzumab. There is another targeted medicine called pertuzumab, if finances permit. So you give targeted therapy plus chemotherapy for 4 to 6 months and then do surgery.
Okay.
After surgery, the targeted therapy is continued for a total of 17 cycles. This was what was done.
Okay.
So targeted therapy is either trastuzumab or T plus P, trastu pertuzumab. That should be given for 17 times in a year, every 3 weeks.
Okay.
6 times you do it with chemo, then do surgery, then give 11 injections. This was the rule. Then, when you do surgery, you will remove the lump.
Yes.
Again, the same philosophy. Do you have pathological response or no? So,
Okay.
if you have pathological response, means you have good disease. The disease has responded, it has died. Your previous targeted and chemo has worked and killed everything. If there is something still alive, tumor cell is seen, that means you have not attained PCR. That is, tumor cell is still there. That chemo has not completely destroyed. The targeted has not completely destroyed. That means your risk is higher than PCR person.
Okay.
So this person has a chance of coming back. That's why they give TDM1 here, not for this fellow.
Oh, okay.
For this fellow, they say, your targeted worked very well for you. Chemos we have given for 6 months, so no more chemos here. Continue your targeted for another 11 injections. Total 17, 6 plus 11. 6 before surgery, you have got PCR, no disease, so that targeted is enough for you. For this fellow, they say, you have not got PCR, so from here, 14 more TDM1 we will give you, 14 more.
Okay.
So by adding TDM1 here, when compared to for a similar group of people, by continuing the same trastuzumab, TDM1 had better result. So in a nutshell, HER2 positive cancers, early cancers who don't get PCR with targeted therapy escalate to TDM1.
Oh.
If you have pathological response, don't go for TDM1, continue the same trastuzumab or pertuzumab or both.
But if the results are not better, then add TDM1, so the results will be very good for those set of
Not
patients.
add, switch to TDM.
Switch. Okay, it is switched to. So along with the TDM1, even the Pertu and trastuzumab,
No, only TDM.
Okay. Sir, doctor, this TDM1 is little bit economical to the Indian patient, or it is?
So the original costs around 2-3 lakhs, I believe.
Oh.
Probably somewhere there. The Indian molecule is much cheaper. It is 70,000 or so, 80,000 or so per cycle. Still expensive.
Yes.
But trastuzumab is much cheaper. You get it for 15,000 now. So if cost is an issue, you have to go for trastuzumab. Again, remember, take some anti-HER2 therapy.
Okay.
Either trastuzumab or TDM1. Money is not a constraint. Go for standard TDM1. Money is an issue. Take at least generic trastuzumab, which will not cost you more than 50-20,000 per cycle.
Okay. But doctor, like even the newer technology, if I'm not wrong, correct me if I'm wrong, the cost is also incorporated day by day.
Cost is expensive. So the bottom line is, it is not that patients never used to live before when these medicines were not there.
Yes.
10 years back, trastuzumab used to cost 1.5 lakhs. Today it has come to 15,000. That time, trastuzumab people couldn't afford. Today we are talking about TDM1 and pertuzumab. So the simple message is, some form of anti-HER2 therapy is necessary. If you can afford, escalate to TDM1. If you cannot, take generic trastuzumab. It saves lives.
Wow. Actually, doctor, hopefully in the future might be this pertuzumab and TDM1 also be very economical or affordable by many of the patients, doctor.
They're already economical. They're 70,000-80,000, but hopefully 3-4 years, they should probably even come down
Yes,
with more players in the market.
that will be helpful for our Indian population to afford. Anyhow, doctor, today the session was so educative, doctor. Frankly speaking, many of the new things a patient can go and talk to the doctor, or the patient can seek help from the doctors through this session, doctor. That was something very interesting. Thank you, doctor.
Thank
I'm
you so
very,
much. Thank you.
very sad to say, but the session has came to an end. But thank you, doctor, for your valuable time. Doctor, would you like to give some closing comments to this session, doctor?
Yes. So what I would like to tell our patients is new things keep coming up in medicine. Doesn't mean we have to rush and run to those new things. Number one, most new things still need validation. So don't just say that last month it was approved, so today we will use it. Okay. 2, 3, like TDM1's example only, if you cannot afford, at least trastuzumab should be taken. So these are the few things our patients should remember. And in breast cancer, I would like to reiterate again, it's an awareness month. Do not ignore a breast lump. Do not ignore indrawing of nipple or bleeding from the nipple. Do not ignore an armpit lump. It is the most common cancer in women in India today. It is highly curable. Please show to your doctor as soon as possible and get checked if you have any suspicious lump.
Thank you, doctor. Thank you for this valuable note. I hope this year, the Breast Cancer Awareness Month, obviously not only this month, entire 365 days, we do spread this kind of a message. Thank you, doctor, for the valuable new message, and also for all the patients who are, all the people who are attending this session. Wishing you all strength, hope, and good health from Cancerage. Thank you, doctor. Thanks a lot.
Thank you. Once again, wish you all a happy Dashara.
Thank you, doctor.
Thank you. Bye.
Thank you.